Examine this person's upper limbs neurologically, the motor system. Upper limbs neurologically, the motor system. The motor system. Look, tone, power, coordination, reflexes. Look, tone, power, coordination, reflexes. Look. Ensure adequate exposure. Before testing anything, ask the patient to rest the palms of their hands on their lap. Look for major abnormality of posture or asymmetry in muscle bulk. Is the hand clawed, implying weakness of the intrinsic hand muscles? Look for rest tremor. Proximally, look at the shoulder girdle for wasting of deltoids. If you see occasional fasciculations, then inspect over the trapezii as well. Do not confuse the normal pulsation of the brachial artery with a fasciculation. However, length-dependent neurogenic wasting is usually detected distally, and the most reliable muscle to demonstrate this is the first dorsal interosseous muscle, FDIO. If you are unsure, feel the bulk of the muscle and compare both sides. Ask the patient to turn their palms up and look for wasting or asymmetry of the thenar eminences. Tone. Do you have any pain in your shoulder? Relax completely. Do not try to help me. Examine tone at the elbow. Vary the rate of your movements. And the wrist. If you suspect Parkinsonism, roll the hand around at the wrist to detect cogwheeling rigidity. Power. It is often helpful to perform a screening test first to detect significant weakness. Hold your hands out like this, palms to the ceiling. Close your eyes. Hold it for 10 seconds. Look for pronator drift. Look for involuntary movements. Do not test for a rebound at this stage. It is not very useful. It could be added later to demonstration of the signs of a cerebellar syndrome. Test muscle strength from proximal to distal, testing movements about each major joint. Never test both sides simultaneously, except at the shoulder where simultaneous testing of abduction is acceptable. For each action against gravity, remember to try to observe how far the patient can move actively against gravity before applying resistance. Shoulder abduction. Lift your arms up like wings, like this. Do not let me push them down. Nice and strong. Elbow flexion and extension. Make sure you always use your free hand to support the limb so that only movement about one joint is being tested. Pull me towards you. Push me away. Do not test muscle groups bilaterally at the elbow. Wrist extension and flexion. Again, use your free hand to support just above the wrist. Make a fist and bend your wrist back like this. Don't let me push it down. Bend it forward like this. Don't let me lift it up. Finger extension and flexion. With your free hand, support the palm proximal to the MCP joints. Fingers straighten together, hold it there, nice and strong. Use the ulnar board of your hand to press down firmly. Curl your fingers around mine, don't let me straighten them. Finger abduction, dorsal interossei, ulnar nerve. Spread your fingers and hold them there. Don't let me push them in. Nice and strong. Do not test finger adduction, Froment sign. It adds nothing and cannot be graded. Last, thumb abduction, abductor pollicis brevis, APB, median nerve. Make sure the patient's palm is horizontal, facing up. Abduction of the thumb is movement out of the plane of the palm. Lift your thumb up to the ceiling. Don't let me push it down. If they are still not sure about how to position their thumb, place it for them first. Coordination. Finger-nose testing. Touch their fingertip with yours. With this finger, I'd like you to touch your nose. Observe the first movement closely. It's often the most informative. Now touch my finger. Choose a distance just short of the length of their reach. Back to your nose and back to my finger. Choose 3 different positions. Move to the new position just after they have landed on their nose. Look for sway towards the end of the movement, past pointing. Rapidly alternating supination and pronation. Place your hand on your lap like this. Turn the hand backwards and forwards like this, as fast as you can and as accurately. As well as looking at the coordination of the movements, listen out for the rhythm. The regular rhythm is lost in dysdiadochokinesis. Reflexes. These are examined in the order biceps, supinator, then triceps, comparing each side at a time. Place the patient's arms semi-flexed. Ask them to fully relax. Make sure that they do not couple their hands together. Biceps. Place the thumb of your free hand on the hard tendon of biceps. Hit your thumb with the tendon hammer with a smooth, relaxed action. For the other side, if in leaning across the patient you do not feel that you can get as good a contact, then it is permissible to briefly cross to the other side of the patient and back again. Make sure you hold the tendon hammer like a hammer. Do not hold it too far up the handle. Do not use too abbreviated a swing. Supinator. Place 2 or 3 fingers over the radius above the wrist. Again, 1 or at most 2 strikes should be enough. If the reflexes are very brisk, then asymmetry can be best detected by using the least force necessary to elicit it on one side and comparing this to the effect on the other side. Triceps. With your free hand, take the weight off the elbow by holding the forearm at the wrist. Strike the triceps muscle directly, about 1 inch above the elbow. You should see and feel the elicited jerk. If, despite good technique, you cannot elicit a reflex, apply reinforcement, just at the point when you are about to strike the hammer. When I say so, please clench your teeth. Clench and relax. If we were testing in detail, we could also examine for finger jerks and the Hoffman's reflex.